We know antidepressants increase activity of neurotransmitters like serotonin, noradrenaline, or dopamine. But how do we know they actually work? And more importantly, how do we know they work better than a sugar pill? Well, here's the thing, is statistic, more specifically, biostatistics. Antidepressants are tested using some of the most rigorous and complex statistical methods in medicine. In today's video, we are stepping away from chemistry and looking at how studies are designed to measure something as subjective as happiness. The foundation of testing is the randomized controlled trial. It involves a sample population with major depressive disorder that are randomly assigned to the drug or placebo group, usually in a double-blind setup, meaning neither the assessor nor the patient knows who is getting what. Why? To remove bias. If researchers were able to choose who gets the drug, they will naturally give it to the sickest or healthiest patients. So each individual within the sample population would be randomized to either the drug or placebo group. But in psychiatry, randomized controlled trial faces a massive, unique problem, and that is the placebo response. In many depression trials, sometimes up to 30% of the response is attributed to the placebo, natural history, or just the relief of being in a study. Therefore, trials must be designed to detect the difference between the drug and this high placebo baseline. If the drug only acts like a placebo, the trial fails even when the result indicated the patient had gotten better. How are depression measured statistically? The simplest way to do this are questionnaires or rating scales. Most commonly, the Hamilton Depression Rating Scale, or really any questionnaires that test depression would work. But most of the time, researchers use that over the other questionnaires, since it is a widely used scale to assess how severe the patient's depression is. Anyways, Hamilton Depression Rating Scale is a 17-item questionnaire which measures mood, guilt, insomnia, anxiety, and, well, that. This method turns subjective feelings into numerical values, usually ranging from 0 to over 50. The primary endpoint is typically the change in this score from baseline to 8 weeks. If the drug group drops 15 points and the placebo group's 10 points, that 5-point difference is the therapeutic effect. But statistics also deal with regression to the mean. If people with extremely high depression scores were the only ones picked, they are statistically likely to get better over time anyway, just by chance. There must be a way to distinguish between true drug effect and natural recovery. So, after the numbers were obtained, now what? Was it a fluke? Within a randomized controlled trial, researchers use the p-value, usually looking for p less than 0.05. This means there's less than a 5% chance the results were caused by random luck. To be honest, this is a very simplified explanation of p-value. The theory itself of p-value is a very complicated issue. Besides that, biostatisticians also focus on response rate and the remission rate. Of course, testing if antidepressant is important, but another factor that has to be considered is how safe it is for people to consume. Antidepressants often show lower acceptability in the real world than in trials, meaning people stop taking them due to side effects like nausea. Real-world cohort studies often show smaller benefits than randomized controlled trials. This efficacy effectiveness gap is a major focus for researchers trying to understand why a drug that worked in a 2,000 people trial might not work for you. But that alone wouldn't be enough to show the result of an antidepressant being tested in a randomized controlled trial. Even when researchers used the p-value to test if the results are statistically significant. Since the Hamilton Depression Rating Scale is heavily subjective, so what could be done here to solve this? Well, unfortunately, there aren't really any other mathematical or statistical methods that could solve this, since it mainly comes down to how the data is connected. Essentially, the problem boils down to how the trial is conducted, meaning that if there isn't any objective evidence paired along with the questionnaires, it would be very difficult to tell if the antidepressant works or not. Unfortunately, there are a couple of ways to connect objective evidence from MRI, EEG, and blood sample tests to look for certain biomarkers. The future of this field is pharmacogenomics. Instead of trial and error, researchers use biostatistics to predict which drug will work based on your DNA. So the next time you hear someone talk about antidepressants, remember, it's not just a molecule. It's a carefully tested, statistically validated tool designed through the power of data. Thanks for watching.